Good morning, ladies and gentlemen. This is the CII Tamil Nadu MedClave 3rd edition 2023, focusing on the theme Healthcare 4.0 Decoding Digital Transformation. Thank you for joining us today. We start the session with a welcome note. May I now request Dr. Satish Devdas to deliver the welcome address, please. Dr. Satish Devdas serves as the Vice Chairman of Devdas Hospitals in Madurai, overseeing orthopedic surgery at the esteemed facility. Renowned as the premier super specialty private hospital in Madurai, Devdas Hospital boasts extensive amenities and a committed team of physicians. He is the past chairman of CII Madurai Zone, member of the CII Tamil Nadu State Council, and currently chairs the CII Healthcare Panel for the state. May I now request Doctor to please come and deliver the welcome note.
Ladies, gentlemen, distinguished guests, members of the healthcare fraternity, I think almost all stakeholders of the healthcare fraternity are represented here, including the health tech. So welcome you all to MedClave 2023. As convener of the healthcare panel of CII Tamil Nadu, I welcome you to this 3rd edition of MedClave. The last 2 years, I was again the convener in the last 2 years also. And we started this flagship event of CII Tamil Nadu. And I'm very happy to say that these are the first 2 years were like baby steps. And this year we have really progressed quite a bit. And even the last 2 years, we were able to bring in all the stakeholders of the industry. And it was a very successful event last 2 years. We were trying to bring in all the latest technology. We brought health tech people, we brought health insurance. We got other industry leaders to speak to the healthcare sector. And this events were in the last 2 years were very successful. Another successful part of the last 2 years was the healthcare honors or awards which we gave through the MedClave, where hospitals and healthcare organizations were awarded for their dedication and service. And this was done by a very professional group where the marking system was made and the awards were given. So this is a brief about the last 2 years, and this year, the theme of this year is Healthcare 4.0, Decoding Digital Transformation. It could not be more timely or critical. I always say, doctors are very poor tech people, and they are actually tech illiterate. And slowly we are moving towards tech. I think because all of us now have a phone in our hand, that has made us more, but it's much more now. And there could be the rapid evolution of digital technologies reshaping how we take care of our patients, how it is going to change the healthcare. Already we are doing a lot of work has been done in HMS, EMR, telemedicine. How we are going to go to the next level is what is going to be this conference. So throughout this conference, we'll have an opportunity to delve into the latest trends, breakthroughs, and the best practices in the realm of digital healthcare. We have some organizations who are already doing excellent work, and they will also come and share their experiences with us. And we will make sure that it will reach the end user, that is the Tier 3, Tier 4 towns and cities of the state also. That is a reason why we want to bring this everybody together, make this more reachable and more affordable. So as we come together to explore the digital transformation, I encourage you all to embrace the spirit of innovation, collaboration, and forward thinking. Let's harness the power of technology to drive positive change and shape a future where accessible and personalized and sustainable healthcare is within reach for all of us. So I think I would underline the word reach. So that is what I think we should work towards too. So I'm very confident that today will be both enlightening and inspiring, and I look forward to the enriching conversations and connections we are going to make today. and it will emerge from this gathering. And thank you for being a part of MedClave 2023. Let us embark on this journey of exploration and discovery together. I want to acknowledge the efforts taken by our healthcare panel and the conference chairman, Dr. Ilan Kumaran and Sharmila Devdas, for doing an excellent job in putting together this conference at 9:30 in the morning on a very cyclonic day. We have such a packed audience. I'm very glad that we have worked together to bring this work, and I'm sure all of you are going to thoroughly enjoy the deliberations of the day. And Dr. Ilan Kumaran has worked very hard to bring this, the topics. So much of discussions have taken place between us every week. At least 2 or 3 days we are talking, and it is really nice. I'm very happy the healthcare industry is now teaming up, and this MedClave 2023 is a result of that, and I'm sure it's going to be a grand success. Welcome you all again. Thank you.
Thank you, Doctor. May I now request Dr. Ilan Kumaran Kalyamurthy to deliver the context setting, please. Dr. Ilan Kumaran serves as a CEO of Rela Institute and specializes as a liver anesthetist and intensivist. He completed 6 years of training at the National Health Services in the UK and has obtained fellowship of Royal College of Anaesthetists, London. Over the years, he has played a major role in setting up 25 liver transplant centers in India and abroad. Dr. Ilan Kumaran has published 60 articles and papers in international peer-reviewed journals and books. The governor of Tamil Nadu had felicitated him for the contribution towards Tamil Nadu organ donation program in 2012.
Can you hear me? Yeah, thank you for the nice introduction, Bama. Good morning, all of you. Thank you for being here. First of all, I want to thank the CII Tamil Nadu for giving me the opportunity to chair this event. I also want to thank CII Tamil Nadu Healthcare Panel, chaired by Dr. Satish, for giving us an opportunity. As Dr. Satish mentioned, last 2 months have been really hectic for the whole team actually. So when we have assembled 2 months back, we were discussing about the topic, what to choose, and we have looked into what has happened the last 2 years. This year we thought we'll talk about digital transformation because across the globe, across India, the main topic of discussion is ChatGPT, artificial intelligence, health tech companies, promotions, funding, all these things have been discussed quite a lot. Being a doctor and a healthcare administrator, I thought it's going to be quite useful for the whole industry to benefit out of this discussion going to happen today. So this event will have 3 components. Of course, you have seen the program. We've got 5 sessions discussing various topics about digital transformation. We might think why we need digital transformation in the healthcare. With or without our knowledge, with or without our consent, we will be engulfed with all this technology. You might have noticed that without our knowledge, we have started using Swiggy, Uber, GPay. I don't think we were wanting to use it 5 years back, but it has become a day-to-day practice. The same culture will happen in healthcare. I think it's better we plan on what we need it in the future, and we adapt the technology at the early period of life rather than adapting it a bit later, and we have to prepare ourselves for this. So the part 1 is about the program, whole program, 5 sessions. We are going to talk about artificial intelligence, how we can use the data, what are the government initiatives. There's so much of discussion going to happen. I also want to thank for all the faculty for agreeing to be here. We have got doctors, healthcare administrators, technology experts, AI specialists. We have got people from multiple locations from India and abroad. At least 4 people have come from abroad to attend this conference. I really appreciate their time. Part 2, we also thought we'll use this platform to encourage startup ecosystem. Mr. Rachit from PwC has done a lot of work in the last 6 weeks, conducted many sessions on startup pitch, and then he has filtered out 4 winners among 18 whoever has presented. I think there were more than 50 presentations has happened in the last 2 weeks in PW office. I really appreciate that. And the third part will be honoring the hospitals who are all making a lot of big difference in this state, Chennai and outside Chennai, both in terms of quality of care, patient safety, and technological innovation. So these are all the three components of today's session. I wouldn't want to waste too much of time because there is a lot of discussion need to happen. I wish all the best for all the faculty. I hope that all the delegates will have a great time today. Thank you very much.
Thank you, Doctor. Now let's get started with our first session. Quality of care and patient services in a digital world, impact of real-world data. May I now request Mr. Rajarajan to please introduce and moderate the session. Mr. Rajarajan, a seasoned healthcare thought leader, is a powerful blend of a visionary leader with a global perspective and strong business acumen. He has been leading various successful ventures in India and abroad, especially in areas of multi-specialty hospitals, oncology, cardiology, diagnostics, and health tech. He has led organizations for various accreditation programs like JCI, NABH, and QAI. He is a member of the American College of Healthcare Executive, life member of Consortium of Accredited Healthcare Organizations, the Research Foundation for Hospitals and Healthcare Administration, Telemedicine Society of India, and a life member of Health Records Association of India.
Thank you. Good morning, one and all. Such a pleasure to see a full auditorium, that too on a rainy Saturday morning with all the cyclone warning. We've all braved it and come over here. I would like to quote one of our Thiruvalluvar's Thirukural, Selvathul Selvam, Chevichelvam, Achelvam, Selvathul Ellam Thalai. So I appreciate each of you who has come in search of that knowledge today over here, and this knowledge is going to translate into various applications in your healthcare setting. Thank you for coming over here. So first up, I'm going to introduce some of the panelists, interesting panelists, experts who have come over here. So may I call upon Dr. Gomati Narasimhan on the stage. Madam is a chair of Medical Advisory Board and senior consultant hepatopancreobiliary surgery, liver and transplant surgeon at Rela Institute. She has a background dating back to 2001 in transplant, and she has participated in nearly 2,500 liver transplant and 1,000 kidney transplants. She's a pivotal member of the steering committee. She contributed to the establishing the Tamil Nadu's cadaver transplant program in 2007. Madam also holds a distinction of being India's first female multi-organ transplant surgeon, specialized in liver and kidney procedures, and is a recipient of the prestigious award, Women Leader in Transplantation, at the Annual Congress of the Transplantation Society, Argentina. Good to have you, Madam. Next up, I would like to invite Mr. U.K. Ananthapadmanabhan on the stage. Mr. U.K. Ananthapadmanabhan is an age-old name. He's a very young at heart person with interest towards the tech side of healthcare. He has transformed multiple organizations. He is the founder and CEO of IT startup 10X Health Technologies, Coimbatore. And 10X Health Technologies is actively involved in design, development, and implementation of hyper-automation solutions in hospitals, hotels, schools, colleges, and shopping malls. He's also a foremost thinker with respect to low-code, no-code software evangelist. He's a zoolytic. So he is a phenomenal person who is doing a lot of digital transformation for organization. Currently, he's involved with a major project with St. John's, a very reputed organization doing a digital transformation. Thank you, sir, for being here all the way from Coimbatore. May I call upon Mr. Ram Natesan? He's a Senior Vice President, Network and Provider Management, Star Health. So, Mr. Ram Natesan is a business leader in healthcare, banking, and insurance with over 20 years of experience in senior leadership roles. He serves as a Senior Vice President overseeing Network and Provider Management at Star Health. He has prior professional experience in leadership positions in banking, financial, and notable institutions such as Barclays Inc., Royal Bank of Scotland, and Principal Financial Group. He's worked in healthcare, various major corporates in the region as well. Thank you, sir, for taking our invitation, coming over here, Ram Nitesh. Next, I call upon the session chair, Dr. Sunil Shroff. So Dr. Sunil Shroff is a very age-old name again. He's a urologist and a transplant surgeon. We know him more also as the man behind Mohan Foundation. He'll be talking about that as well. He's a managing partner of Mohan Foundation, and he's also the recently elected Vice President of the Telemedicine Society of India. So Dr. Sunil Shroff boasts an impressive career trajectory, holding notable positions across various spheres of influence as the Vice President of the Telemedicine Society of India and the editorial director of medindia.net. His contributions to the medical field has been multifaceted. With an extensive portfolio in publications and research, Dr. Sunil has edited 6 books in transplant law and urology and contributed to 16 book chapters. He's an academician, he's a corporate leader, he's a surgeon, he's whatnot, he's everything. So good to have my panel on the thing. So we'll start with the questions. I'll also go and take my seat and we'll start. Okay, so we'll start with Dr. Gomati. Madam, what do you think? How can real-world data enhance diagnostic accuracy and treatment outcomes? As a specialist doctor, what do you see with all this data coming in? How is it changing with respect to the diagnostics and the treatment outcomes?
I think that would probably be the last target to achieve, I think. From where we are currently, still doctors have this closed mindset. I would say we are not ready to accept anything other than personal experience to start with, and then comes most places, it's personal experience, then clinical evidence, and then we move on to, more data. So from where we stand right now, to be able to make clinical decisions or diagnostic decisions based on real-world data, we have a long way to go. Ideally, that would be the situation we would want to be in. It could be from both sides. One, maybe because doctors still are not open to the idea. We need to sensitize doctors on these aspects. And also the real-world data has to be more applicable to Indian settings. What we have right now is more international data. We need to start collecting Indian data, make it reliable, make it accurate, and then think about how we can apply it to patient care. I think this is the reality as I look at it.
Thank you, madam. Any of the other panelists would like to add on to it? Dr. Sunil, as a clinician?
I think, our chair, initially, I think, our Dr. Devdas, he very rightly said that there's a lot of digital illiteracy among the doctors, and we're very slow to adopt to digital transformation, which can really revolutionize patient care in this country, because really reaching the last mile and getting the right kind of treatment for the patient sitting in a remote village is only possible if you use digital transformation in this country. The government of India is very keen with all this, the National Health Authority, the Ayushman Bharat schemes and so on, to create this digital transformation. It's very keen to convert all those 150,000 primary healthcare centers into wellness centers. So we do have a big plan in this country. And I always say that in India, we have the best of technocrats, the best of doctors. And if we can bring them both in one platform and show the world how we can bring the remote healthcare right in front, right at the center stage of the world, I think a lot of countries will benefit. The African countries, the other developing countries. None of these developed countries are going to do anything for us. And that's why it's so important, the digital transformation of healthcare. And I think we're heading in the right direction. And that will be my opening remark about how, the healthcare data healthcare data comes afterwards. First, we need to lay this structure. We need to get this data from somewhere. With AI coming in, perhaps we can mine some of the data, the real world data from maybe social media. if not from anywhere else. But there's so much going on the social media front. So, there are opportunities. It's not that we don't have opportunities. We need to think a little bit out of the box. Just like we, missed the telephone revolution, we straight away climbed on to the mobile revolution. I think, although we don't have a lot of data captured in hospitals, I think if you think out of the box, maybe we can capture data which are fragmented, and so it's there everywhere. And maybe we should use that data to come up with some conclusions.
Fine, if you want to add, sir?
Yeah, good morning to everybody. I am a great profounder of technology, and I believe that technology is a tool for social transformation. And as Dr. Gomati was saying, I think healthcare has been very slow in adopting technology. Look at retail, look at banking, look at education, look at manufacturing. Unfortunately, healthcare in general and particularly healthcare in India has been very, very slow. I understand that there are about 40,000 hospitals in this country, big and small, government and private. Out of that, hardly 10% of those hospitals have good HIS, okay? And only 2% of the hospitals have electronic medical records. So that reflects the adoption of technology by healthcare people in India. And definitely, I think literacy need to improve. That is not in terms of education, but in terms of computer literacy. I think we are not that good, and maybe the schools, in the nursing schools, medical schools, we need to have that. And if we have to reach the goal of digital transformation, I think we have to do a lot of work, and I'm sure organizations like CII are creating tremendous jobs. And one point I thought I should tell you in the beginning is that, we talk about data. We talk about data all the time, and some of you seems to be so obsessed with patient data as far as healthcare is concerned. People like me have worked in the non-clinical areas, and be it medical equipment, be it infrastructure management, be it CRM, be it SAP, ERP. There is so much of data into it. So we must find out how technologies like IoT can really harness the data from the clinical setting as well as the non-clinical setting. I am sure Rajarajan will be kind enough to let me talk more about IoT, and he is a good friend of mine, and he will give me more share than anybody else as far as the talking is concerned. Thank you so much.
Thanks. Over to Mr. Ram Natesan, from the healthcare delivery side of it to the provider side of it from the insurance area. How is this influencing the insurance policies, all this data which is coming in? How is this influencing the insurance policies and the premium structure, which could be aligned with patient outcomes rather than a premium based on how much it is utilized and stuff? A couple of weeks, last week I was discussing with you, there was an article which I was also contributing in the Ken, where the main focus has been on skyrocketing prices of the premiums. So what is it that the real world data has given to the insurance world, and how is it shaping the premiums?
Okay. Good morning, everybody. Good question, Rajarajan. I'm glad you have asked that. First thing I want to start off by saying is that the premiums have not skyrocketed. I'll tell you why. Because healthcare companies, insurance companies in particular, cannot increase the premiums just like that, because we have a very strong regulator in place, and we have to really prove to the regulator that your economics are not working out, and that's the reason you are increasing the premium. So it's not as easy as people generally think. And to answer your question on what are we doing on the data, I think yes, it's a very good question. So we have huge amounts of data. For example, at Star Health, we processed 16 lakh claims last year. This year, we should be doing about 19 lakh claims, which means that's a huge amount of data, and how are we using that? There are three things on data I will talk. One is that how it is impacting the customer, Number two, how it is impacting the insurance companies in toto, and how it is providing a better experience for the hospitals. The first, let's talk about the customer. Today, the premiums, the way we are structuring our policies in the last 1 year, particularly after COVID, is that no, everybody need not pay the same premium. So based on the data, based on the availability of the incidence of diseases in India, and the kind of claim ratios we are looking at particular diseases, premiums are accordingly designed. So there is an instant gratification for the customer who is actually buying a policy from us, saying that, no, hey, if you are staying healthy, and if you are able to prove to the insurance company that you are healthy than the previous year, your eligibility for a discount goes much higher. Like a simple thing is that, no, in the app we have built a feature saying that, no, if you walk 10,000 steps every day, and if you are able to put that in the app where we have already given you the link, at the end of the year, if you have walked so many steps, then there's a percentage of reduction in the premium what you pay. That's number one. Number two is, in India, unfortunately, customers over-consume curative medicine and under-consume preventive medicine. So we are strongly encouraging our customers to actually go into a preventive medicine route to progress the onset of curative medicine, which means he doesn't have to get admitted for everything if he stays healthy. So there's a telemedicine model which we have evolved. There is a constant engagement of wellness and giving incentives to customers who can actually go and avail free medical checkups every year because we will be sponsoring those kind of things. That is for the customer. So as far as the insurance companies are concerned, if you look at the way we are operating, we operate on a combined ratio model, which means that, no, if I collect 100 rupees premium from the customer, I will be paying a certain amount of that towards my claims and a certain amount of that towards my management expenses, and I will have a small margin to work with. I don't know how many in this room, sitting in the room, knows the margins of health insurance companies. It is less than 2%. So if I am not able to efficiently manage my balance sheet, I will end up in losses. So health insurance companies have to be extremely careful when they are actually running this business, because they work on a wafer thin margin. So for us as an organization, unless and until we have these claim ratios in control and the management expense in control, we will not be able to show profit to our investors and shareholders, where we also have a responsibility. So this data is helping us to actually design newer and newer products which will be beneficial to the customers, and we are in the process of course we are already doing it, disease-specific products. For example, we have a cancer care product which is given to patients who are diagnosed with cancer. Likewise, cardiovascular. So there are segmented specialty products which is available. So the product is targeted to a set of individuals who will buy those products. So by which we are able to eliminate a better underwriting process than the rest of the things. That is number two. As far as the hospitals are concerned, which we work, hospital is a very important partner in our business. So we wanted to provide the best patient experience, the customer experience at the hospital. That is the reason why out of the 15,000 network hospitals we work, we use data to evaluate which are all the hospitals where we can partner with, where can provide the best customer experience based on a various of factors. So data helps us to understand which are the best hospitals where we can work with, triage our customers. Data will help us to have better products for our customers so that they can pay less and at the same time get the best benefits. And data also helps us to define newer and newer products which will also be beneficial for both customers as well as the hospitals as well as the insurance companies.
Thank you, sir. Over to you, Dr. Sunil Shroff. With respect to all this data, you were early starter of the Mohan Foundation. Can you just tell how you use these data and how Mohan Foundation was formed and how it has evolved using this data?
Interesting. I mean, I'm just trying to see how I can connect all this together. When we started the foundation, in India, actually, in 1997, this is almost 27 years back, 26, 27 years back. At that time, the government of India had just passed a law called the Transplantation of Human Organ Act, and that was in 1995, to regulate transplantation, to ensure that there is no commercial dealing in organ donation, which was very rampant before that, and to also adopt what is called brain death as a form of death. a new concept of death. It's a little different from what we're talking at the moment, but I'll try and come back to that. So the government of India wanted to promote organ donation in this country, take away this commercial dealing in organs, bring in a new kind of legislation, accepting brain death as death. And that kind of, opened up a new area for organ donation. And that area was that organs could be donated not only by a living person, but also by a person who is dead, who is not necessarily naturally dead, but who is brain dead, who are in intensive care, who are, after a road traffic accident or something, who have had a brain hemorrhage, whose brain is not functioning, brain is dead, but the patients are on ventilators, on machines, their heart is pumping, their lungs are going, the oxygen is being given to all the cells of the body, except the brain, and these are temporarily being maintained, in the critical care units. And that was the patients that, if the relatives said yes to donation, you could donate not only kidneys, but also organs like heart, lungs, liver, pancreas, intestine, and so on. So it opened a new chapter in the whole organ donation field. When we started in 97, the concept was new. The adoption of this whole thing was very foreign to people, very alien to people, including the doctors, so it was not happening. But there was a huge opportunity in our country, unfortunately, due to high number of road traffic accidents, and this is where data comes in. We have close to, if you look at the accident rate, the death rates on the roads, we are close to 160,000 people who die on roads every year, of which almost 60% have a head injury as the form of reason for death, which means potentially, if we look at, there are 90,000 potential donors available in this country, just from head injury. 90,000 donors means each donor can give about 8 organs. So you have over 500,000 organs available just from brain death. And we have a huge organ shortage. So this gap between demand and supply could be easily met by brain death, but the concept was new. And this is where our NGO Mohan Foundation started to try and bridge this gap and try to bring this concept of organ donation forward in brain death, where you didn't need to be a living person donating, undergoing the stress of surgery, but a person who is dead. If the relatives said yes to donation, then you could go forward. But after you die, your body is going to go back to, you come from ashes, you go back to ashes. So your body has no use. And the only positive aspect of a sudden, death, which is very traumatic to a family, only the positive outcome could be organ donation, where the person continues to live in somebody else. So this is the kind of concept which we're trying to promote and change the paradigm of the thought process and try and redefine death itself. In the brain death situation, you can also have what is called, we try and promote what is called celebration of life, where you give life to new people, to people, not one, but more than one person. So this is how Mohan Foundation's whole thing concept came up. I mean, I know it probably doesn't connect so well, but the data out there on brain death is available, and potentially it can wipe away the whole organ shortage, provided we can meet, we can change the thought process of the society. By the way, 85% of donations which happen in the Western world is coming from brain deaths, not from living person. In India, 90% of donations happen from living person. So there is a reason for change, and we need to bring the change. And change is gradual. When we first started, we are doing only about 100 donations. Today we do more than 1,000 donations, 1,000 brain death donations, which means we get close to about 4,000 organs. And potential, but for 1,000 donors, we do get consent from 2,000, but 1,000 don't go through for some reason or other. So the change is happening. The change is very slow, but it is happening. But looking at data, there is potentially a huge opportunity.
Yeah, that opportunity which could translate into mandating organ donation in a country. Like, there are Western countries, like if you look at countries like Spain, which has made it mandatory for organ donation. Yeah. So in a country like India, where we are always in shortage of organs, which could help a lot many lives, your data, Mohan Foundation's real-world data, could definitely help us.
At least the policies, the regulations, you can put your policies around this, what is already available, and then build on that. It is just not that you're talking that it's not going to happen. It is going to happen because there is this potentially available organs there. How do you convert is your challenge, and this is where your policies can come in with this data.
As policymakers, we have the support of CII, we have the Tamil Nadu Healthcare Panel, and we appeal that this could be taken up out of this and
I just want to very quickly add one more thing. What happens is transplant is expensive surgery, and transplants only go to rich. That's what is thought. And this was bugging us as a foundation, as an NGO. And in the last 10 years, with the social media revolution happening, one of the positive outcomes of social media has been crowdfunding. And I can tell you that, in the last 10 years, since 2015 actually, not even 10 years, we have looked at the, social media, the crowdfunding data from both MILAP and Keto. And we have helped close to about 6,000 patients for transplants in this country, including liver transplants, which is again expensive surgery, costs 20 lakhs. And many of these transplants have gone to the less affordable, the lower middle class. As a foundation also, we have a scheme where we started in 2021, and we are trying to help these poor people. So we have got, if I remember right in my head, about 6,000 patients have been helped, and we, over social media, through crowdfunding, we have been able to get, I think, about 1,200 crores, I think, if I remember right. Maybe my figures are not exactly, because I didn't look at this in the last few.
So that's a detailed discussion in our CII CSR panel, which would be in a couple of months. Yeah.
Oh, right. Okay. So that's a huge success story. And 15% of these transplants now coming for the less of the overall transplants are going to the less affordable, because most of the transplants are happening in private hospitals. So how do we cater for people who are less affordable? Because transplants, anybody can get organ failure. And everybody deserves a transplant, deserves a second chance in life. And so I think this has opened a new window, and it has shown not only, I was showing this, I had presented this paper in the European Society of Transplantation meeting, and this was a total alien concept to them, that crowdfunding for, patients who are less affordable. So this is what I'm saying, India has a huge opportunity to showcase these kind of examples of success, which everybody can duplicate. And these are all small money coming from people who have a big heart. Yeah. And that's what you need. Thank you.
Thank you. Over to you, Ananthapadmanabhan sir. You are an expert in IoT and how it has its use in healthcare, especially on the non-wearable sector, because many people, we keep often discussing that. Many people actually think IoT, wearable, there is a connection on that, but there are a lot of IoT related things which you can do, especially in the healthcare settings, which can directly and indirectly affect a patient care. So how is all this data that you have with respect to various analytics, how is it generating real world, how is this real world data helping patient care from the IoT space, other than wearables?
Yeah.
We have other sessions where they're talking wearables.
Thank you, Raj. Quickly, I have 4 small questions to the audience. How many of you know what is hyperautomation? Can you raise your hands, please? How many of you have heard about hyperautomation in hospitals? How many of you have heard about low-code, no-code software in healthcare? Low-code, no-code, good number, great. How many of you have heard about day of singularity? A day is going to come, day of singularity, day of singularity. Okay, good. How many of you use IoT in hospitals? Forget about, like he said, not about wearables. How many of you use IoTs other than wearables? A few, good. Okay, I think that's a good perspective to start. For your information, for the people who don't know what is hyperautomation is a new technology where there is a convergence of many emerging technologies like IoT, maybe Wi-Fi, Bluetooth low energy, LoRa, artificial intelligence, real-time location tracking system, all that come together in one platform that is called the hyperautomation. And now we have moved from just digitization to automation to hyper automation. Okay. So I think as former Vice President Naidu said, I think India is said to not leapfrog, but it is said to pole vault, in technology. Pole vault. It's a very nice to use, term to use. So I think we are pole vaulting in technology, and that is where we are now using hyperautomation. Hyperautomation is just not a gimmick or a theory, but please understand it is being used. We have implemented. I have concrete examples to show what we have done. Secondly, low code, no code again is a great revolution that is happening. I think it's a tsunami in healthcare. It is something like artificial intelligence being used for writing codes. Low code, no code software is a software technology that can be used by all of us. You can be a front office manager, you can be a doctor, you can be a nurse, you can be an engineer like me in the hospital, or you can just be an insurance specialist like sir. And all of us need not have to go to an IT specialist. We don't have to know Java, we need not know Python, but whenever we have some workflows, simple workflows, we can design our own IT applications and get it integrated with the main HIS application. No doubt, the hospital IT engineers play a very, very important role. They provide the guide rails for that. You cannot develop one application, he cannot develop one, I cannot develop one, and then there should not be chaos in the organization. Okay, so they serve as the guardrails, and we can integrate all these low-code, no-code applications into the mainstream HIS or EMR through API calls and things like that. That is the greatest trend that is happening, and that's what I'm trying to do in the hospitals. And the day of singularity is a day when the artificial general intelligence will overtake the human intelligence. So for all you know, in this audience, there will be about maybe out of 200 participants, about 50 will be robotic robots sitting, and another 150 will be human people sitting and interacting and things like that. The point is, when Elon Musk says that if the artificial intelligence overtakes the human intelligence, we are all done for. That is the day when when there will be no planet, and then that's why he is talking about interplanetary movement. That's what he is saying. So in IoT, what we have tried to do is, in the hospitals, we have tried to implement IoT systems for managing water supply, managing electricity, managing medical gas, managing fuel, managing drips that is given to the patients, through IoT devices. And maybe we even use IoT. Can you believe we have an IoT device which we fix it onto the wall of the washroom, where each cleaner is given a tap card, and she has to just tap it and say that I'm got inside the washroom. She cleans the washroom, then she comes back, taps, and we know that she has cleaned the washroom. So we also say that if it is less than 10 minutes, that means she has not cleaned the washroom correctly. If she is staying more than 30 minutes inside the washroom, that means she is whiling her time. So just imagine in a large hospital with 1,500 beds, if I have about 20 public washrooms, and you will see, NABH and all warrants that you are supposed to keep a sort of a sheet where every 2 hours somebody writes it, and the supervisor is supposed to come and see and all that. But here in this case, no supervisor, nothing. And the supervisor is also given a card. So the washing person gets inside, washes the washroom, comes out, taps. So just imagine sitting in one central place, the housekeeping manager will be able to see what's happening for the 20 washrooms, 20 times being washed, and there are about 100 washing people. They will be able to get to that granular details. Not only that, please understand, for all you know, Dr. Bhaktavachalam has about 5 hospitals. He has an eye hospital, he has a multi-speciality hospital, and he would like to see what's happening in all the units. So just imagine the power of low code, no code, and also IoT coming together. I think many of us won't lose jobs, but many of us will get different jobs. Please understand that. Thank you so much.
Thanks. Yeah. Over to you, Dr. Gomati. So, from the world of IoT to the deep tech of clinical setting, what we do in hospitals. So we have seen earlier, you did say that acceptance has to come with respect to diagnostics. But treatment has always been the purview of evidence-based medicine. And this evidence-based medicine is always driven by data. Data which is unstructured still in many of the hospitals. And as Mr. Anantha Padmanabhan sir said, 2% of the hospitals does use EMR. So how do you see that structured data or the real world data, the structured real world data is going to have a deeper impact with respect to evidence-based medicine and the clinical decision, clinical decision support systems per se? Over to you.
It's actually, it's pretty exciting to hear a lot of what's happening, especially what Mr. Anantha Padmanabhan said and what is discussed mostly in meetings like this. I've had the opportunity of being on this side and on the clinical side. And when we go back to the clinical side, it's a totally different scenario. How much are we getting this data into real world practice is totally different. There's a huge gap still. I can see Mr. Devdas also acknowledge what I say, because these are two different parallel worlds running. We need to be able to connect the two if we have to maximize the benefit of this onto patient care. I think there's a huge gap between that. Also because for clinical decisions, a lot of data has to come from the clinical side, and we're far from documenting that. So the way I think we can use technology is to make it user-friendly, really usable, and make it mandatory but not in an obvious way. So clinicians can continue to give us more data, accurate data, and only from that can we move into really decision making based on that. So unless these two happen, we will still be running parallel, worlds. So that is one thing. And second thing is whatever data is available has to be accurate, needs to be applicable to the current scenario that you're working in, which in Indian setting has to come from data from not just 2%, but from at least 30-40%. And for a very simple example, very recently we had a meeting where I had to present data on the percentage of male and female donating organs. So to get this data accurately was a big task for me. I could get it from our hospital, but to look to registries, there was 30% data was not available from registries just on the gender. So you can imagine how much we lag behind in terms of data collection. I think we need to start from there, from the clinical side. I'm not trying to be negative or pessimistic. I think ultimately we need to get there, but we need to really work closely towards getting this.
Raj, I want to add one more point on this.
Go ahead.
How technology, because we are in the insurance industry, we process a lot of claims. So of late I'm seeing technology has actually driven medicine to a different world altogether. Whether it's being a robotic surgeries or minimally invasive surgeries, oral chemotherapies, nuclear medicine, advancements in technology, bringing down the allows of treatment options. Earlier, about 3-4 years back, the number of modern medicine, we call it modern treatments, was less than 2% of claims. Today it is 6%. In the last 4 years, there is a 200% jump in claims, particularly for the modern treatments. One thing is about robotic surgeries. Robotic surgeries is absolutely done in every organ today. So that was not the case about 4 or 5 years back. And I remember about 5 years back, the number of robotic machines available in hospitals was in single digits or double digits. Today, I talk to all large hospitals, they have multiple machines in multiple companies doing multiple surgeries. So that's the way technology has actually driven. It has ensured better clinical outcomes, faster recovery of patients, better mobility, and of course, better patient experience. So technology has really improved the way we deliver healthcare to our patients from a clinician's perspective, and that we are seeing from an insurance point of view also. The number of claims rising clearly shows the trend is moving towards that. One doctor was telling me some time back saying that, Ram, in the next 5 years, you will see at least 30% of the surgeries in India happening with robotic surgeries. So that's the way we are moving towards that. Thank you.
Thank you. Thanks. Robotic surgeries are on the rise. Next, I'll throw a question to the audience. Probably I'll ask Mr. Jai to volunteer first from KG Hospital to talk about some of the technology-driven aspects in your hospital, which you have been able to bolster with respect to the data which is generated and the outcomes which you wanted to achieve. The mic is right there. You know, you also have a Harvard release also on some of those, so you could, I thought I'd pick your mind to educate the audience here.
Hello. Myself, Jaykumar from KG Hospital, Coimbatore. Using IoT technology, we reduced carbon emission in our hospital. We use solar power and we reduce 30% of consumption of regular electricity. This is one implementation, and we use digital technology where patient need not wait where to go, when to go. In health checkup department, the patient waiting time is more for any counter for ECG or echo or blood collection. The patient after registration, the system will guide you where to go, where is less waiting time. This two technology we introduced in our hospital, which is successfully going on. Thank you.
Thanks. So on that, you know, patient care and patient safety related projects well brought out. So when you look at the patient safety aspects, with respect to, you did mention about the ESG related aspect of carbon emission. That's the most talked about topic, and we do have green credits coming shortly, wherein every hospital, other than your CSR activity, we also, or every organization rather, need to be doing that. So on that note, Dr. Sunil Shroff, telehealth has been at the forefront on this ESG because it does not require people to come to the hospital. And especially with the kind of evolution in the last 2-3 years on telehealth, can you highlight some of the aspects of telehealth, the patient care and safety aspects, the do's and don'ts from the guidelines? I know you need to get it all in 1 minute. It's not justice, but still we are at a shortage of time. Another 10-12 minutes, we need to wrap up this session. So over to you.
Post-COVID, I think during COVID, obviously telehealth was one reason why we could save so many lives. And I think, you know, COVID also has been able to help us with easier kind of, you know, acceptance of digital transformation in healthcare. And I think, you know, telehealth will continue to play a very major role because so far for last 20 years in India, we were very challenged to get telehealth accepted both by doctors and the patients. Today, you know, hybrid form of care is here to stay. I'm not saying that it's going to be only telehealth. Many of my patients now prefer coming online, especially who are in slightly remote locations, who are in a distance. India in the world has done the maximum number of teleconsultations, by the way. We have done almost 1 billion teleconsultations since COVID. We have a large experience in telehealth consultations. One of the things which we have a little challenge in India is identification of the doctor, because many reports indicate that almost 30 to 40% of practitioners who are practicing out there are not having valid qualifications, and they don't have registered medical practitioners. So that's one challenge which we have. That's one barrier. The government of India again has, trying to overcome that by digitization of the National Medical Council records. What we must also realize is telehealth also has made patients more empowered with information. And today we are moving from illness to wellness, as you know, and from managed care to self-care. If I ask you in this room, how many of you are wearing a smartwatch? Raise your hands. I'm sure many hands will come up. And if I ask the same question about 5 years back, there would be no hands going up. So the change is coming. It's coming gradually. We are being more conscious of our health. I think, telehealth also will bring prevention to the forefront. It will also help, the insurance companies to bring down their premiums. Because with prevention, care will be better. You will have less people falling ill. So I think there is a movement, and I think telehealth has definitely helped. And I think India has again set an example and shown the world that we can make a difference.
Especially through the e-Sanjeevani as well. You know, all the private players have chipped in.
200 million consultations, teleconsultation on e-Sanjeevani. It's not a small number by any record.
Thanks, Doc. Over to Mr. Ram Natesan. You did mention about this incentivization aspect with respect to the number of steps and the premium reduction and stuff. So what are all the other aspects you think it is coming up with respect to health insurance vertical as such with all this data? How patient care is going to be disrupted? How are you disrupting the patient care?
Okay, good question, Raj.
Adding benefit to the patient as such.
Absolutely. I think among all the industries, as someone was mentioning before also, healthcare is one industry which is not yet seen any disruption, particularly in the health insurance space. We are still working on the old conservative model of, getting the claim in the system, processing it, and then settling the claim based on merits and all those things. But that's slowly changing. At least at Star Health, we have taken a cognizant effort after COVID to see that we will have to change the way we approach our business. So what are the three things that we are looking at is, one is data-driven decision making on how we can, change the behavioral economics of the entire ecosystem. So behavioral aspects changing of a customer is very important. So while the premiums are increasing, premiums are rising, people complain to me that now the healthcare costs also is rising. The price what we paid to a hospital 5 years back and what I paid today has gone up significantly. So which means the only revenue I get from is the premium paid by the customer. So naturally I'll have to protect my interest at the end of the day. And I told you that now we operate a wafer thin margin. So how do we can maximize use data to ensure that our customers get the best available product and at the same time pay a lower cost? So there are three things to that. One is that I have already shared with you that when you start moving into a preventive medicine, if you keep yourself healthy, then we'll be able to give you a better premiums. The second thing is the loyalty bonus, which has always been there in the system, but here we are trying to work out based on the available data. Like for example, if you have reported four free claim years and you are trying to pay a fifth claim year, then 4 free claim years, there is a small weightage discount which we are proposing. We'll add on to the 5th year so that the premium of the 5th year paid by the customer will be slightly lesser. And that's another way of incentivizing the customer. The third thing is what we are doing is, whenever a customer buys a product, before he or she buys a product, we are trying to evaluate the health of the customer, of the patient, saying that, look, you are in this age group, you are likely to get into these kind of diseases based on your health records, again driven by data. And there is a telemedicine consultation also which happens from our side. Just to add, somebody was asking about telemedicine. We do 1,000 telemedicine consultations every day at Star Health, 1,000. The initiative was started after COVID and we do about 1,000 teleconsultations. It could be for various forms. We try to avoid admissions where it is not actually warranted. So by doing this telemedicine kind of a consultation, we will be advising the customers, look, this is not the right product for you. You might be paying more money by taking this product and you may not get the claim as per your request. So you move into this product. So something called as value-based care. That's what we are coming into. And we're also doing one more thing is that, since we have a huge repository of data, I'll be able to tell you that in Chennai, how many TKRs claims we have settled in the last 5 years. In Bangalore, how many CABGs we have settled. So likewise, the entire country we divided into multiple zones and we know exactly what is the disease burden in each location, basis which I can design a product. If I see, for example, in the Northeast, we see the incidence of cancer very, very high. Similarly, in the coastal areas of Kadalur, Pondicherry, Chidambaram, we see high number of cancer cases coming in. Likewise, when we have this data, we are able to design specific products for specific locations at a much lower premium. Today, premiums are uniform. Whether you buy a policy in Delhi or you buy a policy in Tirupati, it is the same. But we are trying to change that so that a customer living in Tirupati doesn't have to pay the same amount of money because the costs are there much lower when compared to a customer in Delhi. So we are trying to gamify the whole process and trying to bring in these new changes. Added to that, we are also bringing in OPD products. Today, insurance is only driven, as I said, for IPD. But there are no OPD products available standalone which includes dental coverage also. So we are coming out with a product. There's already a product available in the market. It's a standalone OPD cover which covers your consultations, diagnostics, pharmacy, and investigations. So this product will also help customers to choose their health at an younger age. And in India, unfortunately, between the age of 30 to 45, they are the least insured. They are the least insured population. It's very hard to believe that that's a fact. So we are trying to bring those people also into the insurance fold by giving these kind of new products, so that they will have to pay less, at the same time get better services, and of course move the patients from illness to wellness.
And I also want to say that you are the first to actually cover telehealth consultation also. I remember that when.
So thanks for bringing those insights, lesser known insights to many of us over here. So Padmanabhan sir, so for you, interoperability issues, is it really a big thing? Because we can talk of IoT, we can talk of the data that it could generate, we can talk of the various outcomes that could be achieved with respect to patient care, patient safety, but interoperability issues, the change management and the proactiveness required at various organizational settings. Can you throw some light on those?
I think it's a very, very important aspect which we have to look up in a large country like ours. How many of you know that Government of India has come out with digital health standards? How many of you know that, we have now got digital health standards. Like you have NABH standards, you have now got digital health standard. And organizations like us, I'm part of CAVO, and we are trying to create awareness on digital health standards. We are trying to organize a training program on 17th of December on the various chapters, objective elements and things like that. And such standards help us a lot in interoperability. And now government is coming out with ABDM and all that, so Ayushman Bharat digital mission, where they have defined all the protocols and the API calls, everything they have done. They are also trying to accredit some of the service providers. They talk about M1, M2, M3. So once you get into M3, then your HIS standard, your HIS can communicate with any of the HIS around the country. And I think that's very, very important step and a very vital step that is happening. And before I close, I just thought we are talking about data. So view not only in patient care, but also in many other areas using IoT. You were saying about using IoT in electricity. Now we are using IoT in water management to manage the water supply, manage the water consumption, manage the water levels, water quality, TDS and things like that. All is done through the IoT. Then we are also managing the ambulances. You have about 12 or 13 ambulances in large medical college hospitals. We have fitted IoT devices in the ambulances. We have also used low-code, no-code application. We have integrated it with the HIS, so it seamlessly operates through that. And one interesting thing is, in energy management, the AC consumes about 65% of the energy in the cost of electrical energy in a hospital. So what we have tried to do is to put IoT devices in 40 different places like operation theaters, ICUs, maybe laboratories, even mortuaries and things like that, and we monitor the temperature. The Government of India has mandated that you should have, in comfort zone is about 22 to 24 degrees centigrade. So we are able to continuously monitor. The problem with BMS is that it is intranet only, it is not internet, and we cannot continuously monitor, and it is very, very expensive. So this gives you a huge amount of data. You are talking about data. In fact, I envision, I am trying to have a vision where if you have about 100 hospitals in the country, and if all 100 hospitals have IoT devices connected to all their engineering and facilities management system, maybe a professional organization like CII or maybe FICCI or somebody can do benchmarking of all the resources. They can just say per square feet of this building, you should consume so much of energy. Per patient, you must consume so much of energy. So we will be able to monitor from the central location and tell you that you are up to the standard, or somebody is spending more money, or somebody is spending more energy and things like that. So we should come out with a national monitoring agency for all these resources, and if that should happen, that will happen only through IoT. So you will find that in course of time, in another 5 years' time, every medical equipment, every furniture you are sitting here, every TV, everything will be IoT enabled, and then without, like you have USB port in every laptop, IoT enablement will happen. So that will be a great day that will happen very soon. Maybe in another 5 years you will see that happening. Thank you, Raj.
Raj, on interoperability, I want to add a quick point. I think most of the hospital leaders sitting here would acknowledge what I'm saying is that GA Council along with IRDA and insurance companies are working on an interoperability model of settling claims. There's something called as National Claims Health Exchange, which is being worked upon, and it is going to be a reality in the next few months, which means all claims sent by hospitals to insurance companies will go through that exchange, which will become a nodal kind of a point and start getting disseminated to other insurance companies, and likewise the claim settlement. So what happens is two things. We are going to have a huge amount of data to understand the disease burden in the country, which will also create a model for digital health in India, which is going to be monitored by the Ministry of Health and Government of India. So National Health Claims Exchange will also to a great extent bring down the fraud which is happening in the system of fraudulent claims which is coming to the system to a great extent, because today insurance companies are not talking to each other. But with NHX coming in full-fledged, already workshops have been conducted, all the hospitals have been oriented. Whichever hospitals has got good HIS systems are being roped into it in a pilot. And in the next 6 months to 1 year, you will see at least 50 to 60% of the hospitals in India working on the National Claims Health Exchange, wherein three things will happen. One is that the prevention of fraud, abuse and waste will come down significantly. It will be a hassle-free claim process for the hospital. There will be faster realization, and the most important thing is patient experience will go up tremendously because it can significantly bring down the discharge time. Thank you.
Yeah, so thanks. My 2 cents on that. The National Claims Exchange is going to be great. In fact, it is also going to bring in the OP cashless 100%. So we are all looking forward to it as the health fraternity. Secondly, it is also getting integrated with the Ayushman Bharat digital mission. So hats off to the leaders of the country who are putting it all together in such a nice way. So for want of time, we'll just go ahead with the closing remarks. And over to you, Dr. Govardhan.
So again, going back to the clinician's perspective, I think what Mr. Ram Natesan was talking about, the incidence of disease in specific areas, the age group, that's all just fantastic for a clinician. If we can get that information from insurance, when I say we as clinicians, I mean if all insurance companies and people who have this kind of data can collate it and be able to share it with the clinicians, that will go a long way for us in taking decisions or helping us with patient care. I think that would be the day when I would say real world data has made a difference to the clinical practice, and that's something we look forward to.
I think, as a generation, we are very lucky. We've seen many revolutions in our lifetime, and we are sitting on a revolution with AI, being right there now. So I think, healthcare generates 30% of volume of data in the world today, of all the data. And this is going to grow to another by 6% in the next, apparently, 5 years. So that means 35% of all data in the world is going to come from healthcare. So there's a huge opportunity to mine this data for the benefit of human beings. And I think there's a huge opportunity for India in healthcare, provided we are able to align ourselves and get our policies right. Already we have a huge amount of data lying in silos, be it health insurance companies, be it diagnostic services, be it intensive care. We don't have, these are areas where we have clean data, because AI requires clean data. Electronic health record, again, is fragmented and not necessarily captured in timelines. It may be captured in one timeline and then the patient comes for follow-up, it's not there. So that's fragmented, but there are a lot of clean data available in the country. The challenge is going to be how we're going to mine this data. And you're talking about in a health exchange area where the government of India can have all the data available. I think we need to think cleverly in India if we really want to make a difference in health. And I think healthcare is one area where we can really make a difference, because we, as I said right in the beginning, that we have the best of the computer technocrats and doctors. So I think I'm very excited looking at the future, and I'm sure we have an opportunity to take this forward. Thank you.
Yeah, I think to sum it up, I think I was just telling doctors before also, before the start of the session is that see, healthcare is an ecosystem. It is not just only hospitals alone. I think it's a combination of hospitals, allied services, insurance, and of course the most important person in this entire ecosystem is the patient. So if we can actually keep patient at the center of this thing and start working towards that, all of us in tandem, when we can draw synergies and work together, I think this industry will move into a completely paradigm shift. Unfortunately today, we are still working in silos. So I think all of us should come together, exchange thoughts and ideas, the best practices, so that each one can contribute the way they want to, because all of us have to coexist in the system. Hospitals need insurance companies as much as insurance needs hospitals. So that's a reality. And in India, if you look at the penetration of insurance, the way it is growing, I remember 10 years back, it was 80-20. 80% was cash, 20% was insurance. Now it is almost 50-50. And the way the industry is growing, we are growing at the rate of 25%. Star is growing at the rate of 30%. The day is not so far that in the next 10 years, insurance will dominate cash. So which means insurance companies have to more cohesively, closely work with hospitals and vice versa. Similarly, the entire ecosystem around this, whether it's a digital transformation teams or teams that are supporting systems or verticals, everywhere, everything has to come together. So I strongly believe in a collaborated working environment where we draw synergies and work. I think we need to have more forums, more meetings like this, more thoughts and ideas exchange. And I congratulate CII for putting up a fantastic show like this. Thanks to Raj, thanks to the entire office bearers. We look forward to such kind of interactions more and more from you. Thank you.
Yeah, maybe I should have the last word, right? My name is UK Ananthapadmanabhan, but Raj made me as IoT Ananthapadmanabhan. So anyway, I love that title. IoT is a great device, and something in a large hospital. Just imagine there will be about 2,000 to 3,000 IoT devices in course of time. 2,000. You call it ventilators, monitors, infusion pumps, maybe motors, maybe temperature monitoring devices. We will find in another 4 or 5 years' time, there will be about 5,000, 6,000 IoT devices capturing data. And it is not about capturing data. Like you said, how do you manage the data? What is the insight you get into the data? I think that's going to be very important. It is going to be very exciting and interesting. And the one thing I thought I should tell you is that the technology adoption should be driven from the top. It is very, very important that the top leadership should buy the idea of adopting technology. And now it is time for speed, it is time for scale, it is time for innovation, and all will happen in the bedrock of technology. Okay, so I think we are in the most exciting time. We are not in the bullock cart era. Maybe we are not in a time of day of singularity, but we are in the very interesting time. Thank you, Raj. Thank you, CII, for giving us this opportunity. Thank you very much.
Yeah, we are open for just 2 questions for want of time. Please to the mic.
Good morning, all. Thank you so much for this opportunity. My key point is that healthcare information systems is now the only need of the hour because it is the backbone of healthcare delivery. So IoT will help in access in rural areas as well, and for remote patient management. That's what the company I work for does. So healthcare information is the key focus now because it connects all the various IoHT devices. We need to integrate chatbots, artificial intelligence, virtual reality, augmented reality, and all this in the healthcare information system. So do you feel that should be the key point of focus? And this also includes the fact that inquiries about donating organs, organ donors and recipients, all that should be in one healthcare information systems, and that should be the new point of focus in healthcare. That's my key point. Would you all agree with me on this point, please?
I don't think so anybody will say no to that. We are all in agreement to what you said. Of course, HIS is the most important aspect, and it can integrate all the different domains, whether it be patient, be it hospital, be it clinician, be it insurance company, and so on. It can connect. I think, we need, having said that, I think it's so important, the Government of India came up with telemedicine practice guidelines. But what they did come up was standardization of these HIS softwares and hardwares and exact requirements, what we should be doing. I think that's where we are a little stuck there. And that is the standards policy committee, which is there, sitting out there in Delhi, which is a little slow in turning around. But when that happens, I think this will be one of the most important aspects, and we need to look forward to this, how we can take it forward and make it part of, a accepted kind of norms for, let's say, NABH accreditation or any accreditation, that it should be part, that you should have this standard and this should be available in this hospital. So there is a standardization, so that we can get the data out as you want. As you said, everything integrates to one point.
Thank you very much.
One more question.
Yeah, last question.
Thank you. Good morning. See, I am from academia. As one among the 140 crore Indian citizens, just please throw me some light on how long I have to wait to access my data, patient data.
Patient data access. Now, okay, so just to throw a light, every patient has access to their data in paper form from the hospitals and stuff. There are individual setups, systems, wherein you are also able to get the data. Each hospital has their own software or their third-party arrangements, applications, through which they are giving the data. But the National Digital Health Mission, the Ayushman Bharat Health Mission, is putting together an app. The sandbox access has been shared with as many third-party people in the country. Now that integration is happening. Now, one more thing which is happening is the data, like we will be talking about it, hospitals can upload the data, patients can upload the data through these registered applications as well. And through that, then only we will have a very longitudinal healthcare data available for hospitals or for healthcare settings, also for treatment, or for tech companies, also for interventions and flagging off, and also for the patient to understand in detail of it. It is work in progress at this point of time, and we hope that it comes a reality.
I just want to add one very important point. I think the question you raised is very, very important. There are two ways of looking at it. One is you get admitted in a hospital in Coimbatore, you get admitted in a hospital in Madurai or someplace. Previously in those hospitals, we didn't have these mobile applications. We didn't have this HIS. What we had was paper documents, okay? Yeah. So if you wanted a lab report, you have to go to the medical records department, ask, they will give you a printout and things like that. But now, in fact, I was in Trivandrum last week, and I went to a IT company, and they have made everything into mobile. So you can, if you go to a hospital in Trivandrum, maybe if that HIS was working, you can just access your record, provided you give a consent, provided the hospital gives a consent, you will be able to access your data when you went into that hospital, not the hospital outside Trivandrum, okay? Yeah. But what government is trying to do is through the ABA. Now many of these IT providers, service providers are now coming out with ABA. It's an ID given by the government for like Aadhaar, and you have to integrate it with the Aadhaar number of yours. Yeah. And these IT companies, either they take the ABA and update their UHID, or from their UHID they create you an ABA ID. So I think in another 4 or 5 years time, I think your question will be answered and you will have access. I can be sure India is all set to do that. When it can do for Aadhaar, when it can do for UPI payment, it will do it for ABA as well.
Thank you, sir.
Just to add, with ABA, you can start buying insurance policies. That's the way the industry is looking forward to. But only thing is, we'll have to check the authenticity of data. Today, Aadhaar is there everywhere. Likewise, they want to integrate ABA. With ABA, you can buy policies, you can renew policies, you can even port policies.
Thank you, sir.
Which means the insurance company will have complete access of your healthcare profile, which is a big challenge today. Because the number of admission rejections in the insurance industry is 25%. And 50% of that is because of non-disclosure of PEDs and material facts. This will be completely eliminated with ABA.
Thank you, sir.
No, this detailedly in the afternoon session also. Good. So we'll discuss that. So for want of time, I'll just close with the closing remarks. So everywhere data is there. In healthcare settings, we have been following this data. like say for example the antibiogram that which we generate, or even the EQUAS data that which we get, the external quality assessment survey data that we get for getting our laboratory related test in order. So today we did have this great panel discussion. Next slide. So in a hospital, see, predominantly the healthcare setting, the healthcare delivery systems are points of data generation. Either the patient directly or the healthcare setting is a point of data generation. And there are various other aspects related to various third parties who are accessing this data. Now all this is coming under regulation. We all know about the DPDP. We have a wonderful session sometime later in the post-lunch where we are going to discuss how to avoid paying that 200 crore fine. The next slide. So the important aspects is real world data is already existing amidst us. We have to tap into this data, not only clinical decision support systems, but operational decision support systems also has to evolve based on these data. Today, in a hospital, when you enter, right from the time the security notes down your car number to the time you come back, there are about hundreds and hundreds of non-clinical data points, very unstructured. So that's why I've ably titled this data everywhere, but not all are structured. So we have so much data, and with respect to clinical data, it runs into thousands and thousands of it. So all this, how are we going to structure it? That is going to be the start of the data transformation. That would set you into 1.0, 2.0, 3.0, and Industry 4.0, which we are talking Healthcare 4.0. The interventions and outcomes, some of the industry experts did mention about how they are using that in their system and how it has delivered results. And I'm sure many of you out here also have that in your systems. But be cautious about how this data is used. How do you secure the data? We do have sessions on that as well. So it's going to be interesting and packed session. Let's hear it for all the other panel. And thank you all for braving the storm and coming over here. And please give yourself a big round of applause. Thanks for the panelists as well. Over to the organizers. Thanks.
Thank you for a wonderful session.